Oral health indices. The goal of preventive dentistry goals are to avoid disease altogether. In order to maintain disease-free state, this usually is we reach this through primary prevention before getting the disease, through lifestyle changes which are made early since childhood, and even preventing artificial feeding through breastfeeding, the risk of developing dental disease will be minimized. What do we mean by lifestyle changes? Less carbohydrates, better oral hygiene, improved nutrition, and better education. If we go to the second stage of secondary prevention, when the disease starts, which is the main work of the dentist in our country in these days, we have to reverse or arrest incipient caries. We can use to reverse the initiation of the disease. The outcome is good health could be achieved through aborting this process. Far too often, the dentists spend most of their time treating dental disease, an endless cycle of repeat restoration. So actually better is to start primary prevention before getting the caries. Dental caries is actually a very large scale epidemic in the world. We can see there is an indicator for dental caries, which we will speak about later on, DMFT, which include dental caries, missing and filling. This is, if we just look to this table, we find that it is common, especially in developing countries. In developed countries, it is less. And as the child grows up, the figure is usually increasing. We see that dental caries is common even in developed countries. We see in the United States, uh, 5 to 9 years, it is 50%. When they are 17, it is 78%. While it is 100% in China, for example, 90% in Mexico. The prevalence of caries has changed over the decades because of preventive programs. In every developed countries, there has been a steady decline in dental decay because they apply preventive programs, especially using fluoride in water supply in the United States since the 60s. Experts believe that it was primarily introduced through fluoride therapies in the 60s. We must know the disease etiology in order to prevent it. The impact of dental caries in children is not affecting only the teeth. It will affect the health and development of the child, because poor oral health is detrimental for children, nutrition and growth. And oral health is also connected with systemic health. It can result in heart problem, in addition to the dental ache and abscess and destruction of the bone locally. It also has social impact and school hours loss. It restricts the child activity. Oral disease are divided into dental decay, periodontal diseases, and oral cancer. As I mentioned, water fluoridation, which was started in the 60s in the United States, resulted in significant reduction in dental caries among school children. Topical fluoride application, in addition, or fluoride rinses, and even fluoride in the dentifrice is also important factor in preventing decay or caries. Flossing is also important and maybe complementary for dental brushing. Now we come to the indices used to measure the prevalence of dental caries. Commonly used indices include DMFT, which is decay, missing and filling teeth, total, and when we put it in capital, this is for permanent teeth, and this is for primary teeth for children. Oral health index and community index. We have also plaque index and gingival index. What do we mean by dental index? An index is defined as a numerical value describing the relative status of a population on graduated scale, with definite upper and lower limits designed to permit and facilitate comparison with other populations, classified by the same criteria and method. This is an important definition. Any index to be used should have many characteristics, should be simple, clear, reproducible. We can find it again and again, quantifiable or measurable, and acceptable. It must have a high validity and high reliability. What do you mean by validity? Validity in Arabic, مصداقية. It should measure what we want to measure, while reliability is بالعربي تكرارية. When we do it again, we will get the same result. What about the sensitivity and specificity? Sensitivity, الدقة, measuring the positive cases, true positive, while specificity to exclude the negative cases, true negative cases. In all diseases, the WHO put the International Classification of Disease, ICD, and start from 1, 2, 3, 4, 5, and it will reach to International Classification of Disease 10 for dental assessment. In the 10th International Classification of Disease, put by WHO in 1992, we find that caries carries the number KO2 and KO2 1, KO2 3, according to the level. If it is limited to the animal layer, it is 2.0. When it reaches into the dentine, it is 2.1. When it reaches the cementum, 2.2, and arrested caries is 2.3, while odontoclasia it is 2.4. If it is unspecified, 2.9. These are the indices. The plaque index was put by Soundness and Lu. We can find the number of decayed teeth and missing teeth and the filling teeth. This was introduced by Henry Klein and Carroll in 1938. For example, if we visit a class of 44 pupils in a school, we have 35 decayed teeth and 21 missing and 8 filling for the total number of students. We add them together and we divide it by the number of students. So if we add 35, 21, and 8 and divide it by 44, the number is 1.45. This is the DMFT for the class. These are the instruments used for measuring or finding the decayed teeth. Criteria for identification of caries. Lesion is clinically visible. It should not be just discoloration. Clinically visible caries, explored by the tip of the explorer used in this process. The principles: no tooth is counted more than once. Each D, M, and F are recorded separately. Each tooth is recorded once. If it is decayed and with filling, we cannot report it as decay and filling, only filling. Residual teeth are not included, only for permanent teeth. If there are mixed teeth, we must put two indices, DMFT capital and DMFT small letter. The tooth should be erupted, and an erupted teeth is the occlusal surface or incisal edge is totally exposed. The WHO introduced modification for this index. What are these? All third molars are included. Temporary restoration are considered as D, and only caries cavities are considered as D. What do we mean by D? Decay. Indicates the number of permanent teeth that are decayed, and we must remember that we counted only once. Missing, this is for teeth missing because of decay. If it is missed because of trauma or other reason, it is not included. Filling indicate number of permanent teeth which have been filled. Multiple filling is counted once. For individual DMFT, we add the decay and missing and filling. For a group, for example, as I mentioned in the class, we divide it by the total number of persons. This index have limitations. A clear limitation is that it does not take in account the depth of caries. It does not indicate the number of teeth which are at risk. Invalid for older patients because of there are many reasons for losing teeth other than caries. Can be misleading in children because of teeth may be lost for orthodontic reasons. And it is not significant for root caries. Limitations, it is applied only to permanent teeth, capital DMFT. Advantage, it is more sensitive. Disadvantage, take longer time and may require radiograph. This is the MFS, which is we have to include the surfaces also, all teeth surfaces. Posterior teeth have 5 surfaces: facial, lingual, mesial, distal, and occlusal, while anterior teeth have only 4 surfaces. So a total of 128 surfaces are for adult. For DF, decay, extracted filling, this is for decidual teeth for children. Primary teeth, maximum score is 20. For a child, it is 88 for surfaces. If we find mixed dentation in a child in the school, for example, Caries indices for primary and permanent teeth will be calculated separately. We cannot add both of them in the index. A study was carried out in Karbala District College, and DMFT was 2.65 for all the students, undergraduate students. No significant gender difference was found. This was last year. There was no significant difference between study years. The second index is Oral Hygiene Index, Simplified. It is one of the most popular indicators for determining oral health status in epidemiological study. It was developed by Green and Vermillion in 1960. It has 2 components, the debris score and the calculus score. Here we choose specific teeth, for example, tooth number 16 and 11 and 26, 46 and 31 and 36, as it's clear in the figure here. We use only these teeth to measure this index, and when we measure debris, we depend on the size of the teeth covered by the debris. If there is no debris, 0. small area 1, larger area 2, and if it covers most of the teeth, for plaque it is 3. For calculus, similar measure is used. The index OH, Oral Health Index Simplified, we add the debris and the calculus together and divide it by 6, the number of teeth used, and the maximum can be 6. Also, we have advantage, disadvantage for oral health index. It take less time because just specific teeth. It's easy to score, useful in survey work. Disadvantage, results are biased. Index is not sensitive, and it is not ideal for clinical trial. For periodontal disease index, we have an index introduced by Ramfjord in 1959, Periodontal Disease Index. Here we have plaque, calculus, and gingival. It adds the gingival periodontal component in addition to plaque and calculus. In this index, plaque index proposed by Soundness and Liu, we take in consideration the thickness of the plaque at the gingival area. 4 gingival area are used. Similarly, if there is no plaque, 1, a film adhered to the tooth, score 2, moderate accumulation of soft with gingival pocket, and score 3, abundance of soft matter with gingival pocket and on the tooth margin. Plaque index proposed by Soundness is assessed, as we told you, the thickness, procedure. Tooth is dried and examined visually. The explorer is passed across the tooth surface. If no plaque adhere to the explorer, we give a 0. And here these are the teeth examined. At the end, we add the score for all the surfaces examined, and we divide it by the number of teeth, and it is 1.5, for example, here. If we have, for example, if we examine a patient and we find that the index is 1.5 for maxillary right first molar, 1.3 for the right lateral incisor, and so on, then the index of the patient is, we add these and divide it by their number, the average, 1.4. If the index is 0, it is excellent. If it is 0.1 to 0.9, it is good. 1 to 1.9 fair, and 2 to 3 is poor. The plaque index of Soundness was developed by Soundness, as I told you. It includes also gingival index in addition to plaque and calculus index. the same surface of the teeth are scored. This index is applied to longitudinal studies because it includes the extent of the pathology. The most frequently used index in evaluating Soundness Gingival Index. Bleeding is the most important criteria of inflammation in this index. The gingival condition around each tooth is examined and the score for mesial, distal, buccal, lingual area is recorded. And these are the scores for normal gingival: 0, 1, mild inflammation; 2, moderate bleeding on probing; and 3, severe inflammation, mark readiness and edema of the gingiva. Scoring for gingival index: the sum of scores from the 4 areas of each tooth are divided by the number of teeth examined. We find the average. Because bleeding on probing can be scored more objectively than visual assessment of the change in the color, the intensity of probing with a blunt instrument must be carefully controlled. We need to be very generous, and we not to dip the explorer, which causes bleeding. Basic intention of this index is not to assess the depth of extent of pocket to determine bone loss, but only evaluate status of the gingiva. The other important CPT is Community Periodontal Index of Treatment Needs. We take each letter from the beginning, so it is CPITN. Introduced by WHO in 1982, the mouth is divided into 6 parts. We examine using a special probe, WHO probe. The score is identified by examining one specified index. These are the teeth 6, 1, 6 for the upper and lower jaw. This is the WHO probe used in examination. The score: 0, no periodontal disease; 1, bleeding on probing, calculus, pathological pocket; 3, pathological pocket or more than 6 millimeter, and when only one tooth or no tooth are present, we give it X. Treatment needs score criteria: no need for treatment, personal plaque, professional plaque, or deep scaling. 3. CPT index: 3 indicators: presence or absence of gingival bleeding, supra or sublingual calculus, periodontal pocket subdivided into shallow or deep. This is the probe used for CPT examination. We divide the oral cavity into 6 parts, 6 tenths, and we examine each part of these 6 divisions. These are the number, the teeth number which will be examined in this CPT. The sensing force used should be no more than 20 grams. It needs to be a person to perform this test need to be trained, because excessive pressure will cause bleeding and will give wrong diagnosis. A practical test for establishing this force is to place the probe point under the thumb nail. It causes blanching. This is the amount of pressure need to be used. The depth of insertion read against the color of coding. The score consists of from 0 to 4. 0 healthy, 1 bleeding, 2 calculus, 3 pockets, 4 to 5 millimeter, and if more than 6 millimeter, 4. These are some references for this lecture, and thank you very much.